We're here with Dr. Holly Geyer, and she is an internal medicine and addiction medicine specialist. She is also a national speaker on the topics of opioids and addiction, and she's authored over 120 publications. She is also the author of the leading patient-focused book, Ending the Crisis, Mayo Clinic's Guide to Opioid Addiction and Safe Opioid Use. We're so glad you're here today with us.
So good to be with you, Ken.
So today we're going to be talking about how to stay safe on opioids. So there are uses for these drugs that are beneficial to people, and the idea is to, avoid the problems that come with these as well. So maybe we better start with the basics, and that is what are opioids?
So opioids remain right now the most common prescribed drug for pain management in the United States. And quite frankly, we are the users of opioids in the world. In fact, more than 80% of all consumed opioids occur right here in the US. We like our drugs, but there's a reason for it. Opioids work, and with moderate to severe pain, they remain one of our greatest arsenals to managing it effectively. The problem with opioids is when they're used inappropriately. The wrong patient, the wrong indication, the wrong dose for the wrong length of treatment and the wrong route. That's when they cause problems, and that's most often when they see them used illicitly on the streets.
So you mentioned moderate and severe pain. Is that what you refer to when you say, what types of pain are they for?
Yeah, we like the World Health Organization scoring ladder, which really helps us decide what types of treatments are best for what types of pain levels. Many people have probably seen the pain scoring sheet, right? So on a scale of 1 to 10 or 0 to 10, what's your current pain? And for those people that are scoring higher, 5 to 10-ish, those might be populations that might benefit from an opioid as opposed to trying something less aggressive, like a Tylenol, ibuprofen, naproxen, something from that whole what we call NSAID class. It really depends on the individual and also on the indication. The scores don't tell us everything. And, I talk frequently about my patient playing Candy Crush and 12 out of 10 pain. I've seen that, and I've seen stoic farmers who are, in horrendous pain from some underlying disorder with a grimace on their face that score at a 2. We really want to understand what's not just the emotional experience of pain as an indication, but what's the likelihood that person is experiencing pain to put together the picture and know what to offer.
So you prescribe these medications, and then obviously there's potential complications. So what is it that you want to be concerned about when you are taking these drugs?
So anyone who watches late night television is familiar with the drug side effect profile that we are mandatorily required to offer every time a new drug makes it to market. And you'll have someone happily talking about how such and such drug will improve their irritable bowel symptoms, but it'll cost you your firstborn child diarrhea for the rest of your life, heart disease, cancer, diabetes, and a host of other medical complications. If I were to show you the side effect profile of opioids, your jaw would drop. You would say, who would take these drugs and why? And the reality is, in most situations, people won't experience the more serious complications of opioids. Constipation, maybe a bit of foggy thinking, nausea are some of the more common ones. What we worry about with opioids are the two most severe complications. That's the risk of addiction and the risk of overdose.
And so if we were to talk about it again from the perspective of dependency, I would assume that anyone taking these drugs for a long period of time could end up with an issue with dependency. But again, what's the difference between that and this topic of addiction?
So we've talked in a previous episode that dependency in itself can be physiologic, your body's response to the drug over time with recurrent exposure. That's very different than addiction or substance use disorder, where essentially you have lost control over that drug and you're using it for other indications in many circumstances. Dependency can be common in anyone receiving an opioid, typically after more than 2 weeks. And it's essentially your body going through withdrawals if the drug's not in the system, or experiencing tolerance, meaning higher and higher doses are required to get an effect. Those are expectations in opioids, and they don't mean that someone's addicted to be dependent on them. That being stated, we've recognized that over time, chronic exposure to opioids can lead to kind of this stacking effect where we're seeing more and more behaviors in individuals with chronic exposure to the point we can call them addiction. More than 45% of chronic pain patients who are screened with opioid addiction tools are actually found to have addiction with chronic exposure to opioids. And there was a great study done a couple of years ago that showed if you offer a 7-day prescription for opioids, there's around a 7-ish% chance you're going to be on opioids at 1 year. You increase that prescription to 30% chance, 30 days, there's a 30% chance you're going to be on opioids at 1 year. So chronic exposure does make a difference to the development of dependency and potentially addiction.
And this is why if you do take these drugs for a legitimate reason, for, you need them because, post-surgery or something else and something significant, this is why the doctor is not going to just say, stop taking them on this day. There's probably going to be some sort of process to wean off of these drugs, for lack of a better term.
It really depends on the dose and also the drug. For most individuals, if you're on it for about 2 weeks or so, no decline as a taper is required for most people. If you're on them for 30 days plus, there's a good chance that you might need to be weaned off them. And most people will be able to tell if they're feeling that between doses they need more and more medication to get the same effect and or start experiencing withdrawals. It is key that people talk with their providers about that so that they know how they can be handled to taper off.
And I bring that up because I think there's a fear out there that just by taking them, I could become addicted to them.
What we tell people in general is that no one is immune. The odds of it happening to you aren't great. And there are certain risk factors that place you at higher risk. But the American Medical Association had done a study a few years ago and found between 3 to 19% of people that are exposed to opioids will develop dependency over time. You don't want to be on that higher end of the number. And of course, there's risk factors that place you there. Some of the more common risk factors include any history of addiction in itself to other substances. This includes easy stuff, alcohol, right? Tobacco. Those are setting up the brain pathways to allow what could be opioid dependency in the future. Mental health disorders can be very common. And this is the easier stuff, right? Depression and anxiety, not just the severe mental illnesses like bipolar or schizophrenia that put you at risk. A family history of addiction. It's estimated that about 50% of addiction cases we recognize have some degree of family history component to it. There's other things. Longer you're on the drug, the longer you take them appropriately or inappropriately puts you at risk. And then of course the type of drug that you're on. Some of those that lead to higher or more powerful euphoric or happiness surges could also place you at risk. So it's important, if you have any of those risk factors, speak with your provider early so that you can be screened and then monitored while you're on the drugs carefully.
Yeah, that makes sense. And I guess if you are prescribed these drugs, we should get into a little bit about, let's get into the basics. How do you store them? I mean, it seems pretty straightforward that they probably should not be accessible to anyone.
Lock them up. A couple of years ago, we watched the national life expectancy of our children start going down in America, and that was heartbreaking. They've identified that in part that was due to children accessing opioids. We don't want to continue this trend. We are not losing the next generation to something as easy as a storage problem. If you have opioids in the house, they go in a locked cabinet or a locked cupboard. Now, I know when you're in pain, it's so easy to keep them on the bathroom counter or somewhere they're accessible or even in your pockets. This is not where those drugs belong. Lock them up. And when you're done with them, meaning your pain is well controlled with alternative mechanisms, it is absolutely key to get them out of the house. Don't save them for the next home do-it-yourself project, right? It's essential you bring them back to either a DEA-approved take-back location. Many pharmacies across America will accept them, or on DEA-approved take-back days, which are held at least once or twice a year.
So when it comes to disposing of them properly, that is the preferred method to dispose of the unused pills.
Absolutely, yep. You're going to first want to take the bottle, scratch off all identifying information related to what that drug might be, because people do go through garbage cans. And then the drug itself can be crushed and then mixed with unpalatable substances if you can't find a way to take it back. That's, old cooking supplies from the kitchen, that's kitty litter, my cooking, anything that's easy. And then destroy of it in multiple locations, such as a couple different garbage cans.
And the key is not to pour it down the drain, is what I understand.
Surprisingly, that is a option according to federal websites. We are seeing increased water contamination with that approach. So I would say if you have any alternative, I would take it.
So what medications should you tell your provider about if you're being prescribed opioids?
We know that certain things put you at greater risk for overdoses in addition to risk factors for addiction, which we talked about a minute ago. Risk factors for an overdose, according to the CDC, can be due to other medications you're taking. So it's key, talk with your provider about anything that you're on, but particularly anything that's sedating. Sedatives, muscle relaxants, and alcohol are the most common ones we see. Sleeping medications can be included in there as well. Ask your doctor how to take these two conjunctively if you're going to be taking them at all. Now, other things I would say, risk factors for an overdose also include any baseline heart or lung problems. And if you have those, talk with your doctor about them. COPD, obstructive sleep apnea, baseline congestive heart failure. If you're on those medicines, those are risk factors to bring up to your provider as well and say, listen, I'm on these meds because I've got a problem. Do I have to worry about this with opioids?
Yeah, that makes sense. And not only your provider, but what should your friends and your family know when someone's taking opioids?
The first thing I would say to everyone is start with an open and honest relationship about this drug. No one in the history of America or the world has ever taken an opioid with the indication of developing addiction. That is not the desired consequence, which means this is going to be us versus the complication of the drug versus us versus our family as we're taking it. Start off with that mindset. And that means that if and when you as the patient start feeling like you might be experiencing these complications, the desire or the craving to use the drug more often, sometimes illicit behaviors such as going to multiple emergency rooms to obtain the medications even though your doctor said get it from one spot, or using them in a manner that weren't recommended by your provider and how to take, such as injecting it or snorting it. These are all things you need to go straight to your family and say, I'm developing problems. These drugs are starting to take control. I don't want this in my life. Help me. And this is a great opportunity to go back to the provider as one of your first line approaches. Tell them about what's going on, and then they can help direct you to the right treatment approaches.
And again, as a family member, if you start seeing these behaviors, that's a clear indication that there's a potential issue here, and a time to maybe try and intervene in this.
I love the TSA approach. If you see something, say something. This is not the time to allow those subtleties, these little warning signs, be pushed away in the back of your mind. It could cost a life in the world of fentanyl. And so I would say if you're seeing patterns that are abnormal for your loved one, hints of things that just seem atypical, bring them up and speak openly. It is not a HIPAA violation to call up their provider and say, John is taking X medication, he's been on it for X number of days, and he's using more than you prescribed. I'm concerned. Or he's sleeping all day long. I'm concerned. Start bringing up the warning signs so that your provider knows what to do with the next dose.
Yeah, good suggestions, and I think for family members it's tough because you want to believe them when they tell you something, but then you notice that there's a lot less pills in there than there should be, and clearly they're overtaking them. But then they come up with an excuse over and over about why they're disappearing and all of that. And I guess sometimes those statements may be true, that those things may have happened, but unfortunately when you start seeing that pattern, clearly you're seeing something where somebody's really trying to get a hold of these drugs.
When we go through the section on the neurobiology of addiction, we talk about the profound changes that take place in the brain, including an area of the brain called the frontal lobe, which is your executive decision-making center, that go, no-go part of you, that rationalization part of you. That gets shut down with chronic opioid exposure in the setting of addiction. And so when these people no longer have that filter, they can do anything and they can say anything to perpetuate the disorder without that stop sign being there. Family members need to recognize that just because they say it isn't happening doesn't mean it isn't happening. We in the clinical field diagnose the disorder of opioid use disorder or opioid addiction using a scoring system called DSM-5. We do not need patient endorsement to see the features and the lifestyles pretty much associated with addiction to say you have the disorder or you don't, although we love endorsement. So I would say to families, if you're seeing features of it, bring them up to both the patient as well as the primary care provider, because you might be spot on.
And in the worst case scenario, somebody either accidentally, takes too much, or even potentially they may have, purposely taken too much. And it comes to the issue of what we're experiencing now with all of these overdoses. And a lot of people have heard of Naloxone or narcan, as it's known. And I guess the question is, who should be carrying that?
So naloxone is a medication that reverses an opioid overdose, typically very quickly, but on a short-term basis. It's available over the counter, and the drug has some miraculous effects in helping individuals that might be experiencing either reduced respiratory rate or not breathing well in the setting of an opioid overdose, responding less, turning blue, some of the major features that you would need to look for if someone has taken too much opioids or in the wrong route. Now, the key to using it is making sure that you're carrying it. And so really there's a debate in the literature as to what population that is. With it going over the counter, I think the government is sending us a clear message that they want this everywhere and available. I'll tell you a personal story that I was at a park, and in fairly affluent park, just a couple of years ago with my 3-year-old. When I heard screams across the end of the park, I raced down there, and there was probably a 12 or 13-year-old lying on the ground, blue. Him and his friends had been experimenting, and I was there, and I didn't have naloxone. And had EMS not arrived in time to help reverse that opioid overdose and whatever else he was using, I honestly probably would have lived with that guilt for life. And so my personal opinion is that people could really consider carrying this with them now that it's freely available to use in situations where someone might be experiencing one. Absolutely, if you're high risk for an opioid overdose, both you and your family member should have this on person. High-risk populations, baseline heart or lung issues, using other sedatives like benzodiazepines, muscle relaxants, or sleeping agents. And then anyone with a previous history of an opioid overdose or high risk because they have an addiction problem. Those are great situations to keep it on you. What I will say to our general public is treat every single opioid overdose as a medical emergency. Call 911 immediately when you're giving that drug. I believe in another section we're going to actually show people how to deliver that drug. It's quick and simple. And keep in mind also, when you're delivering that drug, don't be fearful of whether or not it's not a true opioid overdose, because the safety profile is extremely good. So if you're giving it and it's not the right indication, odds are they'll experience no side effects.
So even if it isn't an opioid overdose, then giving them this is not necessarily going to cause any harm.
You got it.
And so the only other thing I've heard recently is, now a lot of these opioids, in particular like fentanyl, they're being adulterated with other drugs. And I know from what I've heard that some of these other drugs are not going to respond to that. So could you talk about that just briefly, because it seems like that's a trend.
You're absolutely right, Kim, and it's a disturbing one. In fact, we've recognized that the synthetic opioid class, things like methadone and fentanyl, and all of the other 30 plus that we're now seeing on street with street value, have higher requirements for naloxone to reverse it, and the drugs last less long in the system. I should say the naloxone lasts less long in the system when it's given. So there's a great reason maybe you want to carry 2 vials if you're in a high-risk situation with someone who's using opioids inappropriately or using illicit drugs. On top of that, just like you mentioned, we know these drugs are often contaminated with other substances like xylazine. Xylazine is a sedative. It will not respond to naloxone. And so if you're giving someone a drug and they're not responding, this is all the more reason to call 911 and treat it as a medical emergency.
And it's available now in a nasal spray, so it's pretty much pretty simple for anyone to use.
Extremely simple, yep.
Well, thank you so much, and we really appreciate that.
Happy to help.